I'm Will Shaplow. I'm the chairman of the McSwain Trauma Education Project. On behalf of Mary McSwain, the executive director, and the rest of the board of the McSwain Trauma Education Project, I'd like to invite you, or you're already here, I'd like to welcome you to the third Thursday Trauma Talk. We do these the third Thursday of every month at 8 p.m. Central Time. And no matter where you're at, when, why, what, or where, if it's 8 p.m. Central Time and it's the third Thursday of the month, we're here and we're talking about trauma. This is one of the things we do at the McSwain Trauma Education Project to sustain Dr. Norman McSwain's mission. His mission was that he felt strongly that everybody could do their best based on their ability to draw from a fund of knowledge.
And I get to take it home.
So it was his mission to make sure that every provider everywhere, whether they're in Buenos Aires, Argentina, Fargo, North Dakota, or Chicago Heights, Illinois, that same pre-hospital care provider had access to the same material, content, and educators that were available to people that were able to go to national conferences. We do that through a variety of measures. The third Thursday talks is one of them that we do. We also put on regional and local conferences where we bring people in that are national speakers, authors, educators, to the smaller venues where people that will never go to a conference might have the opportunity to see this type of content presented. We're also sponsoring educators and, again, always looking for other opportunities to further Dr. McSwain's mission. We want to be able to, at the end of every day, answer his question, which he posed to us daily. What have you done for the good of mankind today? So hopefully this is what you're doing for the good of mankind today. You've joined us for this trauma talk. Without any further ado, well, a little bit further ado, remind you that this is a charity. This functions because people support us. So if you like what you see, if you have ideas, send us your things, if you don't see it here and you'd like to see it, we'll make it happen. Write to us. We want to be your source of last resource. If you're looking for help, if you're looking for material, we want to be the person that makes sure that we can provide it for you or give you access. So if this means something to you and this is valuable to you, take a look at what we're doing and contribute $1 or 100, whatever you've got, we will survive and we can do what we do because of the support of people who believe in what we're doing.
Exactly.
Without any further ado, then I'm going to turn it over to Mary McSwain, our executive director, who's going to introduce to you tonight's speaker.
Thank you, Will. I am honored to introduce Randi Schaefer at our 11th McSwain Third Thursday Trauma Talk. Dr. Randall Schaefer received her Bachelor of Science in Nursing from the University of San Francisco, her Master of Science in Nursing from Widener University. Did I say that right?
Close enough.
Okay. And her Doctor of Nursing Practice from the University of Texas Health San Antonio. For her doctoral project, Increasing Pre-Hospital Transfusion Rates in Patients Experiencing Hemorrhagic Shock, a Quality Improvement Initiative, she collaborated with the San Antonio Fire Department. Dr. Schaefer served 20 years as an emergency trauma nurse in operational units and fixed facilities and clinical and staff officer roles. She deployed 3 times in support of Operation Iraq Freedom and Iraq Inherent Resolve. She implemented walking blood banks and pre-hospital blood banks during her deployments at the unit and strategic levels. She was the program manager for developing and implementing the country's first multi-institutional, multidisciplinary regional whole blood program, comprised of 18 ground EMS agencies, 10 helicopter EMS bases, and numerous hospitals throughout South Texas. She developed a comprehensive program onboarding process for EMS agencies as they navigated the process of carrying pre-hospital blood. She presented the work at over a dozen conferences, including EMS World, Special Operations Medical Association, Air Medical Transport Association, and Military Health Systems Research Symposium. She is the lead author or co-author of 10 publications regarding pre-hospital blood, or low titer O positive blood. She is the CEO and clinical consultant of Schaefer Consulting LLC. Her area of focus is taking her clinical and operational experiences to help improve patient outcomes and make it a little easier for the clinical staff still at the bedside. I have heard Dr. Schaefer talk in the past, and I think that her area of focus to help improve patient outcomes and make life a little easier for the clinical staff is exactly aligned with our mission to improve the treatment and outcomes of the trauma patient. Dr. Schaefer, welcome. We welcome you so much and are looking forward to what you can teach us tonight.
Thank you, Mary. That was a very kind introduction. I feel like I've done a few things, but then my kids are out there rolling their eyes at me that I'm lame and boring. So everything balances out in life. I'm going to go ahead and share my screen so we can jump right in. Let's see. Can you all see the first slide that's up?
Yep.
Perfect. Okay. So as Mary alluded to, I've been really involved in the how-to side of pre-hospital blood. I have a lot of really smart friends on the science side and the research side, and I'm taking that information and how do we translate that into practice? And with my deployments and my experience with blood downrange, able to take some of those lessons and see what we can implement on the civilian side to make it work. So this is really what should you know about what's out there about pre-hospital whole blood. So I do have a disclosure. I am a clinical consultant for several of the products that are mentioned, but we're not here to talk about the products. We're here to talk about the process. So a little bit of the background is specifically when we talk about low titer O positive whole blood, is that used to be the norm. That used to be the standard up through World War II, even through Korea. It was what we gave. They didn't take blood out, break it down into 3 pieces, and then try to put it all back into the patient. This was so standard of care that even if you look at MASH in previous episodes, you'll see them go, start the whole blood. So this was absolutely mainstream. Really, after Vietnam was when things started winding down a little bit, and the blood bank and some of the specialists in oncology got together and said, well, maybe we should be taking it and separating it out and only giving patients back parts of it. And if they do need it all back, we'll do it in a massive transfusion with component therapy. Well, if you look back, there's actually not one single RCT out there that supports taking blood out of a donor, breaking it into 3 parts and putting it all back in together individually actually was the best practice. It really was driven by other decisions. So when we talk about whole blood, this is not voodoo medicine. This is not any crazy new science. This is going back to what worked, and we'll show you why it worked. So in the modern military efforts, when we started operations in Afghanistan in 2001 and Iraq in 2003, we didn't have robust blood supplies. So we had to quickly figure out, really at the hospitals is where we started this, is it would take 1 or 2 sick patients and we would blow through our blood supply very quickly. And there was no way to restock us. So what we did was we did a staggered response as we immediately turned to the clinicians in the hospital and started drawing blood off of ourselves. So if you see there's a smiling Captain Schaefer, only because she got a quick nap while I was doing a fresh whole blood donation. So we had a patient just on the other side of the wall, blew through all supplies. So we were trying to draw off the hospital staff first to get it going. From there, it kind of evolved out into really the Ranger program. If you've heard of the Ranger low titer O positive whole program, pushing that fresh whole blood collection closer to the point of need. And once we had started seeing better outcomes, getting the blood on board earlier was really showing some improvements that we wanted to take that fresh whole blood, which may not always be accessible, and cold store it. And that's really where we started looking at bringing cold stored whole blood into theater in about 2016. And I had the opportunity to be involved in blood in 2005, 2009, and then again in 2016. That's a little bit about where the military, how it evolved to where we're at. Why does this matter? Well, as we started looking at that data, we were trying to figure out where are soldiers dying on the battlefield. Are there areas where we could tighten up our efforts to help decrease that morbidity and mortality? And that's when my colleague, Dr. Brian Eastridge, put together a great paper. It's a landmark paper. I don't think you can go to a trauma conference, especially in the military, without his paper being cited. Looked at where are these preventable deaths happening and why. So hemorrhage was the #1 cause of mortality prior to arriving to the hospital. And then they further subdivided it into extremity, junctional, and truncal sources. The second cause of death was airway obstruction, and the third being pneumothorax. So we came up with this principle of damage control resuscitation, which really, if I could sum it up into 3 pieces: stop the bleed, give the blood products. So we stop that triad of death that you all might be familiar with. So in terms of talking about pre-hospital blood, can we do this? Yes, we can. The AABB in 2015, 2016, recognized that in the hospital setting, when we do emergency release blood, it was traditionally packed cells, plasma, or platelets. With this new amendment to their guidelines, they now said whole blood is recognized as an emergency release product. So you can give it. There's no worries with the FDA. It is an approved standard. And that's their standard. If you ever get questioned by the blood bank, can we do whole blood? The answer is yes. And now we've got evidence from over 20 years in the military of doing it, that it really does. The further we can push out that blood product and damage control resuscitation, the better outcomes we're going to have. As far as civilian implementation, over the last 5 years, all 50 states authorize nurses and paramedics to initiate blood transfusions. Some states have the caveat, though, that there has to be an RN on board to initiate. On the ground side, we're guessing about 80-ish. And I say guessing because nobody really knows. There's a lot of pockets of effort around the country, but no one central reporting place where we can look at some aggregate data to see who's doing it. I'm working on a project with Eric Bank out of Harris County ESD 48. They were actually had pre-hospital blood before San Antonio did. And we are looking at the data. And right now we've identified almost 80 to 90 ground agencies that are indeed using pre-hospital blood in some way, shape, or form. Same with the hospitals. We have a guess, just about 80. Again, there's no central reporting mechanism to draw data from, so that those are the best numbers we have, but I suspect it's probably larger as we're growing our programs here. So why do we do this? When I've talked to hundreds and hundreds and hundreds of medics, and the 2 common things that I hear are, well, Randy, we're only like 20 minutes from the hospital, or we're only 15 minutes from the hospital, so do we really need to give blood? And I say, absolutely. And I want to tell you why you need to be giving pre-hospital blood. So transport time is a fixed variable. You know your transport times from the scene to X, wherever you're going to go. It's a pretty fixed variable. What you don't know is either side what's going on. You don't know at the time of injury sometimes. You don't know that when the illness was setting in. When did the bleeding start? If you're in a metro area, maybe it's pretty quickly if it was a witnessed event that they'll call 911. But more often than not, especially in the rural areas, it might be a while before an accident scene has come upon or a gunshot victim presents. So when did the bleeding start? I don't know. We don't know that. What we do know is that for every 15 minutes, mortality starts doing this. So if you've already got a patient that you can't nail down exactly when that bleeding started, you're already behind the power curve. By the time 911 is called, you're dispatched, you get to the scene, then you add in your scene time. Now you've got your transport time to arrive at the hospital. Well, the other secret I'm going to tell you about the hospital is, unless you're rolling into a level 1 trauma center that has emergency release products in the ED ready to pull out of the fridge and hang on the patients, that that hemorrhaging, that triad of death doesn't stop as soon as you cross over those glass doors. It's continuing. And one of my projects I did at Fort Hood when I was the chief nurse there, so we're the largest and busiest. Well, BMC will argue that they're the largest. They are the largest, but we're probably one of the busier EDs up at Fort Hood. And I was very frustrated when we would recognize that a patient needed a blood transfusion. And by the time they got to the doors, we got the transfer over, we recognized it. I'm calling blood bank. I'm arguing with blood bank because I didn't dot an I didn't cross a T. And I'm watching these patients die in front of me, and I lost it a little bit, full confession. And so I went to the commander and said, we've got to get blood in the ED. So they said, prove it. And I walked around with a stopwatch, and it took about 15 to 20 minutes from the time we recognized that there was a need for a transfusion until that blood is actually transfusing into a patient. So I've added up maybe an hour, and that's many times to die if you keep bleeding for an hour. So what we want to do is push that blood forward so that we can start that resuscitation as soon as we can. And there was this interesting article that came out in GEMS about the time I was training the San Antonio Fire Department. And it was pre-hospital trauma management. Can we do more by doing less? And I thought it was interesting because there's a lot of focus on scene times and what do we do on scene. And this article kind of laid out that if we're going to do interventions, they need to be meaningful interventions, ones that really are going to start tipping the scales in the patient's favor. And more data, again, the odds of death increase 2 to 4% every minute until they reach a surgical suite, or, and this is where EMS comes in, damage control resuscitation is started or MTP is started. So if you look at that previous concept, you all have the opportunity to start effective damage control resuscitation and MTP before the patient ever arrives to the hospital. So effective is resuscitating with blood and blood products. And MTP, that by definition, massive transfusion protocol is, greater than 10 units over a 24-hour period. We need to be starting that MTP in the field and continuing it until they arrive at the hospital. So that's how I want you to approach this as you're talking about pre-hospital blood, amongst yourselves or with your leadership about trying to get it done, is we can do an effective intervention and start damage control resuscitation before the patient ever arrives to the hospital. And meaningful interventions, the data is starting to come out that, yeah, this is the right thing to do. So this is the study that was done out of the San Antonio area by Max Braverman, who is one of the fellows here in San Antonio. And I think Dr. Smith is on this too. I think she's on the line. That patients with the whole blood, their shock indexes started to improve by the time they arrived to the hospital. They actually required less crystalloid resuscitation and less overall blood product in that 24-hour period. So that massive transfusion protocol definition. So these are all great outcomes that we want to shoot for. And then the second piece when I talk to medics is one, hey, the hospital's not very far. And two is, well, we don't really get many trauma patients. We don't really need it. And I would argue that we have had more use for non-trauma patients than we have for trauma patients. And so we started taking a look at the literature and building the body of evidence that it was starting to be used in GI bleeds, OB, hemorrhage, a couple of other areas. And I'm going to show you some of a snapshot look of that. So whether you're in the rural setting, suburban, or in a metropolitan area, there is a big need for blood for non-trauma use. So Karnes County, Texas, it's a big county, 15,000 people in the entire county, more cows than people. They're a low volume system, but you could argue because they are an hour and a half, 2 hours away from the nearest capability that they probably have the highest need. And even out in the rural area, it was 50-50, half medical, half trauma. If you move into the greater Houston metro area for Eric Bank and ESD 48 out there, 60% of his transfusions that they're giving are for medical patients. And San Antonio, which you could argue has a large population of penetrating trauma patients, but they're also surprisingly seeing 40% are for medical and non-trauma patients. And then the other question that's always asked is blood logistics. How do we do it? How do we keep it cold? What do we need to do? So 3 things. Keep the blood cold before it gets into the patient, warm it up while it's going into the patient, and rapidly infuse it into the patient. So those are the 3 principles of the logistics of the blood. And there are a couple options. So there are nice portable coolers now, and that can be used to store the blood. They're all FDA approved, and they have now demonstrated that they are able to keep the blood product stored at the temperatures indicated by the by the AABB and also by the FDA. We've upped the game and actually introduced this little thing right here. This is the back of a blood bag. And on deployment, if the cold stored blood and some of the packed cells were drawn here in the US and processed and then shipped by plane into theater and then distributed by helicopter. So we needed to keep close track to make sure that it didn't go outside of its temperature range. So we applied these little stickers on there, and that's what's called a safety view. And what that does is if the temperature, it will change color if there's a temperature excursion, if it goes outside 1 to 10 degrees or 1 to 6, depending on whether you are using a transport standard or a storage standard. And you can't change this. Once this changes color, it doesn't go back. So if you fix this to the bag, you have some pretty solid evidence that at some point there was a temperature excursion. As far as warming it up, a couple options out there that are now compact and made for that pre-hospital environment. A lot of actually all the equipment that are used in the hospital setting don't translate well to the pre-hospital setting. We have these big, large, bulky, heavy rapid infusers. The technology has now advanced that you can get nice warm blood very quickly, all in a device that's about that big. So there's multiple ones out there. You just have to look at your mission profile, look at some of the costs to decide which one works best for you. And then as far as rapidly infusing it, interesting studies that I'm the original armpit squeezer. I have done that many, many times, but may not be the best method to get it in quickly. Also pressure bags. There are some great cadaver videos out there showing that pressure bags that you pump up the bag and try to push in the fluid is not really delivering what you think it's delivering, the efficiency. So there are a few products out there that you can rapidly infuse that again don't require a big machine, power. The one thing I like about this rapid infuser is that we're seeing a lot of peds patients. So when you're developing your program, think about how you're going to administer blood to pediatric patients when it really does need to be a volume controlled process. And next, we're going to talk a little bit about the blood bank and how to navigate the blood bank. And I like this because all of us that live in the space know that we do things based upon pattern recognition, knowledge translation, and really the guts to take action. We are not risk averse. I apologize, there's a gentleman fixing something outside. I think inherently in emergency medicine, we accept risk, we mitigate it as best we can, but we always know it's there. And when you're working with our blood bank colleagues, they're a little bit different culture. They're a little less willing to take risk. They really like to have it laid out in their manuals and their processes. And it's not a bad thing. It's not a bad thing. It's just a different culture. So when you're talking with them, if you can go in and be prepped on things that are important to them, that helps make your case to show that you can manage blood in the pre-hospital setting safely and efficiently. So some things, there was blood vendors and blood bank. A blood vendor is merely someone who sells their product. So you think of the American Red Cross, you go in, donate blood, you get a t-shirt, a gift card, they take your product and then they sell it to either hospitals or infusion centers or now EMS. Blood bank will often be in hospitals, so they may not have the donor collection capability, but they have the blood product. So if you've gone into the hospital, seen the signs for the blood bank or interacted with the blood bank, that's their product that they're managing through this system, tracking and doing all the lab testing. So you might end up working with a blood vendor, or if you have a hospital that wants to be a partner, you might be working with a blood bank. So two different ideas. It's always nice when you're going in to talk with them to understand who they are and what their mission is. Once you identify who would serve your area, questions to ask might be the additive that's placed in the bag. There's two different additives out there. One is good for 21 days, the other is good for 35 days. Why does that matter? Well, when you're planning your SOP or your operations, figuring out how often you might have to change out the blood or recycle the blood or have a disposition for it. That's a big difference in time. So a lot of them are, for the whole blood particularly, are switching to this additive that's 35 days, which is nice. And when you're talking with the vendor or the blood bank, figure out if it is going to be a product that they are going to sell to you and you don't have the ability to return it if it is unused. Here in San Antonio, we did build our program on the ability for the EMS agencies, if they did not use the blood product, that they could return it back to the blood vendor for credit. So in that case, the agencies were only paying for the blood that was used and didn't have to take that hit every 21 or 35 days if the blood had to be discarded due to expiration. In storage and transport, again, very different meanings in their world. Some of those coolers are approved as a storage device, some are as a transport. So when you're looking at the type of cooler you want, that's something you need to consider. And so this is just really high level view of the blood world. This slide alone, I could probably spend 3 days talking about as I have had to learn how to navigate the blood bank and the blood vendors in this. Hemovigilance, if you can walk in with a process that you can demonstrate, you know how to track that blood from cradle to grave. So receipt from either the blood vendor or the blood bank until that blood gets its final disposition, whether it's returned back or whether it's infused into a patient. So hemovigilance. The good news is as an example, you guys, we deal with narcotics all the time, right? That's something we have to keep really close eye on. So if maybe a blood vendor, blood bank, is a little worried about, well, what if the blood gets lost? I think you can assure them that, the DEA has a vested interest in making sure you don't lose narcotics. You've probably got locked in processes that would, the same principles could apply to blood. And some of that hemovigilance is really if the donor center, does further testing and finds out a donor lied on their application about, potential diseases they might have that are caught and they need to contact you. The flip side is that if the blood is given and the patient has a transfusion reaction, in the hospital somewhere, they need to be able to backtrack every single unit that was given to the patient. So they're going to need to track that back to your agency. And they do validate everything. If you purchase a cooler, they may say, hey, we might believe what the manufacturer says, but we're going to test it ourselves. So don't be surprised if they ask to do their own validation of the cooler so that they can give themselves assurance that it does exactly what it's supposed to do. And one of the interesting pushback sometimes we get from the blood vendors is that, well, if you start this blood program, you're going to be taking away donors from our regular donor pool. And we're short on blood. I think probably everybody on here has seen advertisements or pleas for help in the news. We're short on donors. We need your blood. So what's interesting is a lot of times that is the cry for help is for O negative, because we know that's the most commonly used emergency release product. What's interesting is in the population at large, only about 7 to 10% of the donors are O negative. So if you've got 7% of your population trying to support 100% of the population, it definitely puts a strain on the system. When you look at something like low titer O positive whole blood, you can draw that off of donors that have O positive blood that have a titer of less than about 256 is the cutoff criteria. Now that opens up a much larger pool of donors that can help support the system, and really the O negative can get to the patients who may have a clinical indication for truly O negative blood. Looking at some of the blood product priorities. So if you are faced with setting up your program, what blood product do we use? Well, the Joint Trauma System through the Department of Defense came up with this nice list of recommendations. So the top recommendation is low titer O whole blood. But we know that's not necessarily available to everybody. So it goes down the list from best to least. Now, having said that, I've had agencies that have said, Randi, we can't get whole blood. They offered us plasma. Should we take it? And my answer is yes, because we know big boluses of saline are not great. We know if they're hypotensive, we need to get something on board that's an effective damage control resuscitation. So sure, do plasma. And an example of that is in Northeast Georgia, they've got 3 or 4 agencies that are doing plasma until their blood bank, because their hospital is going to provide it, gets set up to collect for donors to do the low titer O positive whole blood. And I also have to say, I live a little bit in the land of reality that I would love to get low titer O positive whole blood out to everybody, but we know it's not feasible or sustainable. So if you're an agency that just isn't there yet, if you've got a 500 cc saline bolus, that's okay. Let's just be smart about it. Let's try to get it warmed up and infused rapidly to make an impact. And, this is a lesson looking at civilian versus military. On the civilian side, there's a whole lot of EMS agencies out there. And I pulled this number, 73,000 registered EMS vehicles in the US. There's no way we're going to be able to get blood products on all of those vehicles. So I would love to advocate to industry. We need to start looking at alternatives, and that's whether that's the free-dried plasma or the synthetic whole blood. We really need to start pushing for that effort now and not wait for the next war when we tend to ramp up our solutions to problems. By the way, freeze-dried plasma has been used for decades in other countries with great outcome. We use it downrange using an FDA waiver. And as a matter of fact, I just got a text from a group of soft medics that I'm on, and they had a picture of the freeze-dried plasma going into a patient. So it's out there, it's a good option, and we need to start pushing industry to help solve some of these problems. Real quickly, we'll just talk about clinical communication and patient safety. So if you are going to be giving a pre-hospital blood transfusion, you need to be able to have real-time communication with the hospital and really the blood bank that is going to be managing the patient's blood products safely. So one of the things we came up with here in South Texas was EHRs are great. They have some utility, but they do not have any real-time communication capability. And here in South Texas, we had, ultimately 12, 15 EMS agencies that were taking patients to up to 22 hospitals in the area. Of course, no two talk to each other. And then when they came to the military level 1, there is no connectivity for communication of charting. So we had to come up with a way that allowed the pre-hospital providers to communicate. And we used the very, very high-tech approach of carbon copy. Now, this was really funny. It was kind of mind-blowing to some of the younger generation that had never seen carbon copy before. We had one medic who was annoyed that he had to write things down 3 times. And I was like, yeah, well, no, actually you just have to write it once. It goes through all 3 copies. So that seemed to calm him down a bit. So really it's that communication tool. So here's an example of how we did it here in San Antonio. And then here's another example of an agency who took a little bit different approach on documenting the procedure and the communication to the receiving facility. A lot of ways that you can do this. I just really recommend that you do it. And the other piece is leaving the blood bag at the receiving facility. So even if the blood product is transfused, leave it. And I will tell you, I learned something when I started doing this program, 5-6 years ago, is this little thing here is always in a rubber band on the bag. And I called it a pigtail. I didn't know I was there. I thought it was just annoying and never really paid attention to it. Well, it turns out that if a patient's given an emergency release blood product, these are actually called segments, and they take a little scissors and they cut off the segment. So they have a sample of the blood that was given to the patient. And so when they get the patient's blood to do the typing and crossing, type and screen, that's what they test it against. So there you go. I learned something new. It's actually called a segment, and it has a useful value. So we want to be able to replicate the processes that happen in the hospital as close as we can. So we can do that with the communication tool and leaving the blood bag. So if they do choose to run some compatibility testing, they've got the source right there in their blood bank. So as far as the 3 copies, top copy stays with the agency, middle copy goes to the ER, and then the bottom copy, the ER sends down to the blood bank with the bag. And then if they're going to end up doing drawing a purple top or red top in the ER and sending it down to the blood bank. So capturing its use is also something you need to really consider. So the clinical communication tool at this point is not an EHR. The communication tool is not intended to replace clinical documentation. So you still need to get it into your electronic healthcare record. If your EHR doesn't currently have the ability to put in the titer O positive whole blood, make sure that they do add that capability into your record. Other pieces is talking with the local hospital trauma registry to make sure that they have a block in their registry to capture whole blood. They'll have plasma, platelets, all the other components, but a lot of them did not have the ability to do whole blood. So that's something we had to work with our local trauma registrars around the hospitals to get that input. The other interesting piece was that I was surprised that we were giving it for so many non-trauma uses. And it wasn't any great scientific discovery. It was, I have reviewed every record in the region that came in, and I slowly noticed this trend, like, wow, that's not a trauma patient, and they didn't go to the level 1 trauma center. So we started figuring out we need to capture this. So we worked with our area hospitals, particularly in the smaller rural hospitals, and asked the trauma registrar if they would also consider tracking the non-trauma uses, because we had to start developing a process. There is no GI bleed, registry at the local hospitals. There's probably not an OB bleed, but we needed to track it. So those were just conversations with the local hospitals saying, hey, we need your help on this. The other piece I mentioned earlier is that there are efforts across the country to get pre-hospital blood up, but no central repository. And our good friends at Tulane University, and I think Dr. Smith, if I saw she's on the call, have helped develop the Tulane University pre-hospital blood registry. So it is the first of its kind in the country that really is trying to track that pre-hospital blood use. So agencies can contribute from around the country, and we can start looking at some larger scale data. So really like to urge you to think about joining something like the pre-hospital blood registry so we can start doing really aggressive research on its use. And then also consider continuous process improvement as you're setting your program. So you'll want to review who got it. But what was interesting is we wanted to identify who did not get it. Before we, broke our elbows, patting ourselves on the back in San Antonio that we were doing such a great job in getting pre-hospital blood to the patients, we were concerned we might have had a blind spot. Were there patients that would have benefited from getting pre-hospital blood that did not get it? And that was exactly what my doctoral project ended up being, was we looked at all the patients that were eligible to get pre-hospital blood, looking at the P1, the priority one list. And we went through and said, yeah, no, their vital signs, they met the transfusion criteria, but not really clinically indicated. Or yes, this was a miss. And what do we do with that? So we took the cases that we felt were missed opportunities and evaluated it. Was it a dispatch issue? Was it an operations issue? Was it a clinical miss? Was it a training concern on the equipment if it wasn't used very often? So we were able to really hone in on going after some of the challenges that if a patient was missed, if a patient didn't get it. So it turned out to be a mixed issue. Some of it, the dispatching criteria was improved. The discussion about scene times kind of came out in the open. There were some medics that were afraid to wait until the blood got to scene, that they were going to get in trouble for busting scene times. So we really went after some of that. And that's how we were able to start doing that improvement of patients that got pre-hospital blood by decreasing those missed opportunities. So something to think about as a QI project as you're starting a program. And then communication is important. Think about communication all the way from a tactical to a strategic level. And some of that is just this small thing. So this right here is a little plastic card that fits in the top of the blood cooler. Again, this was brought out after a helicopter crew dropped off a patient outside of our region to a receiving level 1 facility. And it was for a 16-year-old female. And unfortunately, the receiving physician and nurse told the patient's family that they gave her the wrong blood type. You can imagine that caused quite a robust response. A lot of issues on that, on how we deal with the families, but in fact, they did not give the wrong blood type. So we needed to figure out a way to communicate, because there are so many hospitals out there, so many clinicians that rotate through. There might be the nurse ratchet on the night shift, and I can say that because I sometimes resemble her, who may not have gotten the memo that it is okay to give low titer O positive whole blood. So we stick this card in there, and if they go to a receiving facility that's not aware, they can hand them the card with the website where they can go to get more information about it and take the heat off the medics at the bedside. And then so that's really kind of at your basic tactical communication at the bedside communicating. The other piece is bringing together the stakeholders, and it's really exciting to see the growth of these coalitions that are coming together. So up here in this middle here is a picture of the San Antonio Whole Blood Consortium. So we met once a quarter, talked about issues that were going on. We'd give a presentation, clinical updates, and in this consortium was EMS clinicians, EMS leaders, hospital leaders, trauma, OB would come. So it was really a multidisciplinary approach to talk about this capability. And now it's starting to take off. So I'm really excited. If you're not familiar with Dr. Ann Petty, she leads a monthly whole blood coalition call of interested partners, and they're taking the same thing, taking a topic and talking about it for the month. Colorado just got their whole blood coalition put together. There's a website out there you can jump onto. And then Northeast Georgia is coming together, and in North Carolina. So it's great that we've got some regional efforts starting to emerge when we're talking about pre-hospital blood. And part of this is a team effort. There is no doubt we could not have done it if it wasn't for everybody coming to the table. So you need the clinicians there, trauma surgeons, yes, but also go out and talk to those OB providers. Maternal death due to hemorrhage is horrific in this country. And a lot of that is happening at home, either before or after delivery. So why are we not looking at really helping decrease those maternal mortality rates by getting them blood when they need it? OB, once they opened up blood in their whole blood in their hospital, started having really good outcomes, and they became the biggest champions for whole blood aside from the trauma surgeons. And also talk to your nurses. I've done more MTPs than I can count. And if you've ever experienced one, they're a fallacy, let's be honest, because you cannot keep up with plasma and platelets and blood and packed cells in a 1-to-1-to-1. It's usually throwing up whatever you've got. And after the end, I'm, on the floor trying to count my bags and figure out what I've given. Well, if you can go to the nurses and say, how would you like your job easier? Instead of all these bags, here's one bag. They've become great champions in this. And also getting the blood bank on board, talking with the blood vendors, letting them know that you're a potential customer. It's not a customer base that they're used to dealing with. They may not even know EMS is giving pre-hospital blood. So let them realize that they can be part of a real-time solution. When we have that acute crisis in the pre-hospital setting. Also, we have evolved the role of the blood vendor here in South Texas to be part of the real-time response for mass casualty incidents. And we don't have the time to talk about that. But when Uvalde kicked off, it was actually the blood vendor had boxes of blood that were ready to go to the scene. And talk with your surrounding agencies. It really is a team sport. If your air has it, talk with them. If you're a ground agency, work with them, because it's a chain of survival, just like cardiac arrest. This is a chain of survival that needs to be done. We're also pushing out into law enforcement. I'm super excited that I got to work with the Texas Rangers, the law enforcement agency. If you haven't seen Walker Texas Ranger, the cowboy hat and the cool badges, able to get them set up for some of their really high risk missions out on the border to carry stored whole blood, and also the ability to draw it fresh. And then one more point is you're talking, with your surrounding agencies, we've done multiple, what we call handoffs or intercepts. So if an agency used up their blood and they're driving right past or through an area that is also carrying blood, they're doing rendezvous, quick radio call. I'll meet you at this intersection, and they're able to hand off the blood and then continue on. So I firmly believe that pre-hospital blood as a team sport has better outcomes. And then real quickly to wrap up here, we'll just talk about, there are some barriers that everybody's has to get through. Some of those are the cost of the blood products and the blood program, and some of the scope of practice issues. So there's a great group of folks that are coming together as stakeholders that are going out and advocating for you to try to get some of this costs recouped, and also looking at scope of practice at state to state so that we can remove those barriers. So I'm really excited that this working is just forming up, but I think there's great things out there to enable you all to provide better care to the patients. And I'm just a soldier. I'm not super smart. I just know that a life-saving intervention given too late is not a life-saving intervention. It's an exercise in futility and frustration. And we're going to see what we can do to help you mitigate that. All right, so let's see. I am going to stop sharing. All right. Am I done sharing? Oh, Mary, you're on mute.
Are you ready for some questions?
I am.
I got one here. What is the comparative availability of O negative versus low titer O positive blood? And then as a follow-up, what is the practical risk to low titer positive versus negative?
Yes, so it goes across the country. Again, about 7 to 10% of the population is O negative. Closer to 34 is O positive. So right there, you've opened up your donor pool. And then the titer levels decrease the risk of that anti-A and anti-B agglutination and transfusion reactions happening. So there, we've looked at some of the data coming out at transfusion reactions of patients that received low titer O positive whole blood versus those that received component therapy, traditional O negative packed cells, and there's no difference. They're the same. And the few transfusion reactions that have occurred when whole blood was used, they were also part of a larger resuscitation. So it's really difficult to nail down exactly, what the offender was or who the offender was.
From me, not from the field, would it be off topic to talk about the logistics a little bit about like an ambulance program that wanted to participate?
We can talk however.
All right, great. Like for the average like community ambulance that says, hey, we want to do one of these things. Can you talk a little bit about what that means to say that you're going to have blood in your program, to what the kind of changes they have to make to their operation?
Yeah. So the good news is the wheel's been invented. We just need to pick out what spinners you want on it and pieces. So the basics of the blood program are there. Figure out how to keep it cold, warm it up, rapidly infuse it. Your protocols are now we're looking at standardizing them. So we pulled from the military, our experience there. So the protocols are already written. There's a lot of sharing of that information. Nobody is holding that back. And I'm always happy to share the different agencies. Getting leadership buy-in, whether it's, on the medical director side or the EMS leadership side, once they hear about the pre-hospital whole blood and it makes sense, a lot of those barriers, there is a cost involved. And it is about, I give an agency an estimate of about $6,000 to $7,000 per vehicle to start up the program. Once those capital items are purchased, it really is the consumables and the blood product that they need to really budget for.
That's very helpful. Thanks. Now, you're kind of like at ground zero for a lot of the like save every cell, stop the bleed, give blood when it's not there. And you mentioned some of the studies that are coming out about the delay, the effects of a delay in getting the patients to the hospital. And you presented at one point, well, I'm sorry to amuse you. The idea that getting blood to the field would have an effect on that. But from your perspective, and particularly because you're in that spot that looks at simple versus complex and a little of both, that some of the time factors are, we are doing things in the field potentially that have very little benefit to the patient versus, getting things moving quicker. Do you have some thoughts on that?
Yeah, we try to keep it simple. It needs to be, transfusions need to be quick. On the flip side of that, there also needs to be a program in place that this doesn't bog down an agency trying to become a satellite blood center. That was part of the balance that we had to achieve. The blood centers, once they were convinced that it could be appropriately managed in the pre-hospital setting, really have become supportive of it. And I didn't mention, when I started looking at the data of who is carrying blood products, I have to give a big shout out to the rural agencies. You guys are all over it. The predominance or the prevalence of blood programs across the country are largely found in the rural setting. I just had the opportunity to present last week to the Metropolitan Fire Chiefs Conference. So these are all the fire chiefs. And the metro side's just a lot slower. We're working on, the whys in the house, but rural agencies are doing a fantastic job. And they need to be given credit for leaning forward in this.
That's a good point. I think our rural audience, which is large, in our discussions from month to month, are doing a lot with little in some cases, and then also being able to fill those spaces. It's like, what do we do in the time we have, and what can we do to do things better? So that's a good point. We do have a question about programs that are participating, how much blood to carry. Now, that decision really isn't on them alone, right? It's about the bank and about rotating the blood so it's not lost.
Yeah, so it's a mix of clinical need and operational. So in San Antonio on our aircraft, we chose to put 2 units of blood. That gave us the biggest operational reach as we cover, 3 hours out to the border. There's some pretty good transport times. My husband is a medevac pilot here, and he had a scene time. It took him 1 hour and 15 minutes just to get to the scene. So 2 units seem to be the sweet spot for the ground agencies. We opted to do 1 unit. And the agency had to decide whether it was going to be on the ambulance or on the supervisor vehicle, a sprint vehicle. And we were very deliberate about this process because we want to make sure that since it is a limited commodity, that we had it widely available. San Antonio Fire Department has 55 trucks in service at any given time. We could have absolutely put it on 55 trucks, but it didn't make sense because not all 55 needed it. So they went with the MOF, the lieutenant in the area to cover it. So it's between 1 and 2 units. It seems to be the sweet spot.
We've reached the end of the night, but one more question about, since we're talking about how much blood to carry, and optimally, the programs are set up so that the blood comes off the unit and back into use rather than getting wasted, correct?
Correct. So with the rotation program that we developed here in San Antonio, days 1 through 14, it's out with the EMS agency. If it doesn't get used, it comes back to the hospital where this is a process, by the way, the blood centers do all the time. It's called short dating. They sell it as a short date. So days, I think 14 to about 35, it goes into the hospital. The use in the hospital has improved so much that there is actually about a 1 to 2% waste rate of blood product, which by the way is a lot lower than the component therapy.
Excellent. You've gone, I've kept you longer. I appreciate your candor and your ability to take some questions a little bit off topic. I'm sure this is of interest to our audience, and I want to thank you again for participating in our program tonight.
Thank you. And I've asked for the audience, if you know a ground agency that's carrying blood, we've done a pretty good job tracking, but there might be someone out there. So throw it in the chat if you know of a ground agency in your area that's using it. I'd love to hear and validate that we're on the right track.
Well, thank you again. Excellent presentation. Thank all of you for attending again. Hopefully you can, if Dr. McSwain was to ask you today what you did for the good of mankind today, you spent an hour with us. And I think that these kinds of things would make him very happy, and hopefully your patients will be pleased with what you've learned today also. I want to thank you for participating. Again, stop by the website, have a look at what we're doing. If you like what you hear, great, tell us. If you don't like what you hear, tell us that too. If there's more that you want to know about, if you have topics you'd like us to present, please let us know. We will respond, to what you're asking us to do. We will make it available to you. We will get it done.